Okay, but I do have a lot to share, and so I do kind of want to get going. Okay. You see, I'm not used to microphones and things like this. Yes, I do some presenting, but this is not my full-time gig, so also be kind with me through this process. Okay. So, ADHD, understanding the diagnostic and treatment strategy. So what is that going to look like today? We're going to go over what is ADHD. Of course, to do that, we're actually going to need to talk, it's going to be easier for me. We're going to talk about what is attention and impulse control, considering that's a big part of it. We're going to go over the diagnostic criteria that's in the DSM. We're going to look at the different presentations as well as some functional consequences that can come from this diagnosis. We are going to spend, I'm going to say, quite a bit of time on the complex etiology, so like hang in there with me through the neuroscience, brain science stuff. I'm going to try to make it as simple as possible, but it is really important to understand this. This is going to be a key piece. So we're going to go over the environmental factors, the genetic basis, the structural brain differences. I am going to dive into more about executive functioning skills because that are 3 words that you're going to hear a lot during this presentation. We're also going to talk about the flip side of ADHD and attention because I think there is a little bit of some misconceptions about attention when it comes to this. We're going to go over the 2 main current theories as well as dispel some more myths. ADHD superpowers, because again, it's not all bad. Getting a diagnosis, again, what does that process even look like? What are some treatment options that are available? And then I'm going to tie in how do those strategies that I talked about earlier actually inform maybe our practice or our care at home, at school, in different environments. And I do have a strategy to maybe be tried at home if you would like. So, and then of course we're going to have time for questions and lots of references. So, essentially, we got to start talking about ADHD by defining what that is. And we cannot have this conversation without talking about the Diagnostic and Statistic Manual of Mental Disorders. DSM for short, because that is a mouthful. So this is a really thick book that includes all those mental health disorders. So the DSM is currently considered what we would say a neurodevelopmental disorder. And there actually was some debate about where ADHD should be placed in this newest version of the DSM-5 when it got revised. But they did land on this part. But being under that neurodevelopmental category. But why I even bring this up or draw attention to this is that essentially as we learn more, research, have different information come to light, that actually does change our maybe practice or the information that we have on a disorder. So we are going to talk about the current diagnostic criteria, but just be aware that this is something that actually has been changing and evolving throughout time. So it's not something that necessarily just stays the same. So in general, the DSM defines those neurodevelopmental disorders as a group of conditions with the onset, in the developmental period, so during childhood, and characterized by developmental deficits that produce impairments or, again, difficulties, struggles in personal, social, academic, or occupational functioning. So ADHD specifically stands for Attention Deficit Hyperactivity Disorder. Some of you have maybe be familiar with ADD, attention deficit, again, kind of hear that kind of terminology. That is a little bit outdated now. It's still relevant, but essentially the DSM uses ADHD across the board for all types, but then specifies, once heard of it, the kind of flavor of ADHD it comes in, if you will. So there's a combined presentation that's going to have the inattentive and the hyperactivity impulsive, but then there's also going to be the potential to get just predominantly inattentive or predominantly hyperactive impulsive. So as we kind of see, there's kind of 2 of those categories there. So you can either have it both or lean towards one or the other. So the population surveys do suggest that this happens across most cultures in about 5% of children and about 2.5% of adults. You might be wondering what happens to the other 2.5% of kids then as they become adults. I will talk about that in a bit. So essentially, I want to take a moment to talk about what is attention and impulse control, since inattention and impulsivity are defining characteristics of ADHD. So starting with attention can be thought of as awareness of some senses or phenomenon happening to the exclusion of other stimuli. So in other words, at any given time, a person is exposed to a lot of sensory information, in the environment, even right now, it is happening. So essentially, we can only pay attention to a limited number of things at one time. So let's take it right now. For example, I'm going to assume you're paying attention to this presentation and looking at the slides. If you're not, that's okay, just pretend with me for a moment here. But I'm gonna assume that you're seeing the slides, you are hearing my voice. Because you're paying attention to those things though, you might not be like noticing the temperature on your skin. You might not actually feel the way your body is supported by those chairs beneath you. And you might actually well, I don't know, it's pretty hard, that food smells delicious. You may or may not notice the odor still in the air. As I'm talking about these things, maybe you even felt your attention shift. Like, oh yeah, I wasn't paying attention to that, but now that you say something, now I can feel that seat under, now I'm like, am I hot or cold? So again, that's just an example about how we pay attention to some things, and this is true for everybody, and we ignore or filter out some other information in the world around us. So if paying attention is kind of honing in on the senses that we are aware of, impulse control is kind of in some ways opposite. So impulse control is essentially about limiting perception. Impulse control involves that skill to filter out thoughts, impulses, resist distractions, to be able to do things even like pause and think before we act. It makes basically that selective, focused, sustained attention over a period of time even possible. So it's also a part of suppressing, I'm going to say, like, again, not only like words or thoughts, but bodily and motor functions as well. So again, how we can get upset, and even though we might feel like hitting somebody, we decide not to, we hold back. So as you see in the next slide, it maybe makes sense why the hyperactivity and impulsivity gets tied together. So essentially, how do we get a diagnosis, or not necessarily how, but like what is the criteria to get diagnosed? Currently, this is going to be for children and adolescents, they must have the following things. So A, they must have 6 symptoms in either category or both. So to get that combined presentation, you're going to need 6 from the inattention and 6 from the hyperactivity, impulsivity category that has been there for more than 6 months. Now, to get a predominantly inattentive or predominantly the other one, basically, yes, you have to have 6 symptoms in one, but then you also have to have less than 6 symptoms in the other. Otherwise, again, we're just going to diagnose you as the combined presentation. So, and again, this has to be over 6 months. I think about it like this. We could maybe have a difference or a change in the death in the family, for example. We might actually see a lot of these things after an event like that. So that's why we want to make sure that this has been going on for a while, and as we get to, in multiple environments, so that it can't be attributed to something else going on. So these symptoms, because it's neurodevelopmental, needs to be present before the age of 12. And again, this has to be happening in 2 environments. It can't just be happening in one. So we need to be happening at school, at home, at a friend's house, at grandparents, whatever the case, daycare, but across environments. We also actually have to, and this is kind of interesting, we actually have to experience a reduced quality of life. So whether that be struggles with academic, social, things like that, but to get a diagnosis, there has to be enough, I guess, impairment or difficulty there for also to meet that criteria. And the process of differential diagnosis, it cannot be better explained by something else. Now, with ADHD a lot of times does go with other diagnoses or comorbidities, as we call it. So that can be a little bit tricky to parse out. But again, it's important to be like, are we getting the right thing that attributes to the symptoms, or can it be better explained by other medical conditions, other learning disorders? Because essentially, even a lot of disorders in the DSM-5 have criteria that are going to strongly overlap. So it's going to take a little bit of detective work to kind of parse out and figure out. So essentially, okay, what are these even criteria? So for inattention, often fails to give close attention to details or makes careless mistakes, has difficulty sustaining attention or during like play activities, often does not seem to maybe listen even when spoken to directly, struggles to follow instructions and often fails to finish tasks, often has difficulty organizing tasks and activity, because again, to do something, there's maybe a lot of components that need to go in there in order to be doing that. Often avoids, dislikes, or is reluctant to engage in tasks that require that sustained mental effort. So that's going to be things like the reading, that's going to be the homework, those type of things. Maybe often loses necessary tasks or like items for tasks or activities, like even though we need soccer cleats every week, it seems like we're always losing the soccer cleats kind of idea. is often easily distracted by extraneous stimuli, again, just other things going on in the environment, or maybe is often forgetful in daily tasks, even if it's things that they should be doing like on the regularly or like are doing regularly, still seem to be a little bit forgetful about those routines. So when it comes to the hyperactivity, impulsivity, again, this one almost like rhymes every time, so I'm really gonna try not to sing it to you, but often fidgets with or taps hands or feet or squirms in seat. There we go. Often leaves their seat in situations when remaining seated is expected. Again, we're on the playground, we're not gonna be like, yeah, you should be sitting still. Like, no, that's an okay environment to be running around. But I'm gonna say, in the reverse, often runs around and climbs in situations where, again, we wouldn't expect it or it's not appropriate to do so. Maybe is unable to play or engage in leisure activities quietly. Again, they might be able to play on their own, but you can maybe hear them, or there seems to be a lot of like loudness or noise associated with that. This often on the go, driven by a mode, or where is this energy coming from? But sometimes it looks like that boundless energy. If you have a lot of energy too, sometimes you can just talk excessively. And included in that is maybe that little bit of like interrupting, often blurts out an answer before a question is finished, have difficulty waiting turns, or interrupts or intrudes on others. Now, interrupt, yes, that can be like a verbal interruption, but I'm gonna say also, we're talking about like intruding, I'm gonna say intruding on personal space, maybe your personal space as a parent or caregiver, maybe siblings' personal space, things like that. It might just come at you with like an intensity or like the need to be like closer and maybe not quite understanding or having difficulty respecting that idea that everyone has like a body bubble or a space around them. So, you know, again, coming back to that kind of, well, 2%, 2.5% of kids, but 5% of kids, 2.5% of adults. So just so you know, it is, once you have a diagnosis of ADHD, it could be possible that you go back and you know what, no longer are you showing that these six symptoms enough to get criteria are present. So there can be a specifier of ADHD in partial remission. So it's this idea that no, not necessarily, kind of a myth that children like grow out of ADHD. However, I'm gonna say symptoms can change in severity a lot over time or with treatment or again, these different things to kind of modulate them. So again, we're not gonna say it's just gonna go away, but it might be at the ability that we're just seeing some of these go away. The key is though, they still have to have impairment. Even though they might have less and are doing better with some of these symptoms, they're still experiencing some hardship there. For anyone that's 17 and older, just in case you're wondering, in an adult, the diagnostic criteria is actually the exact same, only you just need one less symptom, so just 5 out of each category or instead of 6. Yeah. All right, but let's dive into a little bit more about the similarities and differences between those kind of 3 different flavors. So I'm gonna start predominantly with the inattentive type, just because this is the one that actually almost like doesn't look, I'm gonna say like stereotypical ADHD. And when I say that, I just mean a child running around with lots of energy, tirelessly making a lot of noise. So no, this inattentive type can more be like daydreaming quietly in class, feeling anxious or sad quite often, difficulty listening, which again, people might just be like, oh, they're a little bit spacey and that's why they don't listen. They can be really shy. We can even see people-pleasing tendencies. And then again, that gets really tricky when they're maybe making decisions just to please others, but that can be very subtle, right? Sometimes we don't really get insight into that. There is gonna be the trouble maintaining or maybe making friendships. They might even do, again, with kind of anxiety type things, picking at their skin, and that perfectionist tendencies or want to be perfect, again, that might be a potential issue for them. Barclay described people with ADHD inattentive type to kind of have this sluggish cognitive tempo. Essentially, dreaminess, that little bit of fogginess, just working at a little bit of like a slower pace. I'm gonna say opposite, they're almost hypoactive, which is less active. They can do that like staring off into space frequently kind of idea. And again, just looks like they're doing maybe a lot of daydreaming in their own world. So inattentive ADHD might be, I'm gonna say, the trickiest of them to diagnose because of that. And with that, we actually usually see maybe this inattentive type being diagnosed later in life in comparison. Also, females, I'm gonna say, are more likely to get this. And I'm gonna say on social media, I'm seeing more and more about kind of like this female presentation of ADHD. Probably we're kind of roughly talking about that inattentive type. But it is interesting to note that like on here, the bottom one is processing speed is impacted. This is, again, maybe true, but not in all circumstances. Sometimes we only see this maybe deficit or trouble come in when now there's been too much on someone's plate. So again, at a certain level, maybe they can tolerate and handle it, but once it goes past that, then we start to see the troubles come in. So for that predominantly hyperactive impulsive type, that is the one that we see more associated with those behavioral problems. So that is more, and in here, instead of, I'm gonna say more the anxiety, we might see more comorbidities more along the conduct disorder type or behavioral stuff. So that need for constant music, well, we'll come to that later, music is a good thing, but constant movement is that defining characteristic. And so that might be like, again, that talking, fidgeting, interrupting, difficulty waiting their turn. And again, just because this actually is more obvious in its outward presentation, it tends to get diagnosed sooner or when kids are younger. And this is the one that is more associated with males in general. So lastly, as far as like, again, the combined presentation has the potential for all of this, but there are some overlap even between what the predominantly inattentive and the predominantly hyperactive or impulsive are gonna see. And those are things like sleep issues, very common across the board with ADHD. Sensory processing problems, I'm gonna dive into that one a little bit more. Self-esteem is impacted or potentially impacted. Executive functioning skills, there's that words again, they're potentially impacted. And again, high rates of comorbidity and things like mood disorders, and that working memory is also impacted. Again, I'm gonna dive into most of these later on, but let's just take a look at that sensory processing problems. Because again, when I say sensory processing problems, that can look a variety of different ways. So that can be over-responsive, which in some ways we actually say then the sensory hypersensitive, kind of confusing language. But again, it looks like when a person or a child maybe responds to something in a way that is faster, longer, and way more intense than we would anticipate. And again, I want to like preference that, like, you know, say a child's meltdown or things like that over small occurrences. Again, meltdowns are developmentally normal in a large part. So this is when we're talking about it's going beyond what we would expect children at that age to be able to do. In opposition, yeah, we might see overreacting. We actually might see underreacting. So again, they might not look like they're actually responding to much or unaware or slow to respond. So again, this is complex and confusing, right? Because it can like look like this, or it can look like this, it can look like this, like almost opposite of each other. And the third type of sensory processing that I want to talk about is that sensory seeking. Again, this can look so many different ways, but they're craving those sensory experiences. So they may do that by licking, snacking, chewing, finger tapping, jumping, clicking, flicking the tongue, stomping, all the way to even things like clothing sensitivity. Like maybe they don't like to wear jeans because jeans are too scratchy. Or again, there's like certain things, tags. Ooh, tags are the worst. Maybe even things like they always want to use a certain blanket though, or like a certain object of comfort, and are very specific on what that looks like. Maybe when they are, I'm going to say, listening to music or on their devices, it always seems to be at a very high volume or quite loud. And again, maybe just making repetition noises. Spinning, there's all sorts of things that can look like. So when we talk about the functional consequences, it's like, okay, these are the things going on, but how is that going to impact potentially a child or a person with ADHD? In general, it is associated with reduced school performance and social rejection. Again, other comorbid disorders and stuff, there is potentially a higher risk for substance use disorders. Individuals with ADHD are more likely than their peers to be injured. We'll talk a little bit more about that. Traffic accidents and violations are more frequent in drivers with ADHD. Academic deficits, school-related problems, and peer neglect maybe are more associated with this inattentive, whereas that peer rejection, and to a lesser extent that accidental injury, the hyperactive one. So, but again, I just want to take a moment to pause, as that sounds pretty doomy and gloomy. Like I get it, like even me, I'm like, oh, okay, that's a lot of heavy material to throw out there. So I want to just remind everyone that having a child with ADHD does not mean that all these difficulties are guaranteed to happen. And especially, they're not even guaranteed to happen, and then they're definitely not guaranteed to happen at the same time and the same intensity throughout their life. So I know psychologists, for example, who are very much diagnosed with ADHD, and guess what? They went through all the schooling to get to this position. Like, not us. the end all be all. But again, when we're saying it's occupational functioning deficits and school functioning, that's not necessarily the case. So again, I don't want to sell anyone short here of what they can achieve with, I'm going to say though, that accommodation and support and treatment needed for them to get to that highest level of functioning that they can. But again, this is like, yeah, not some kind of sentence that everything is going to be terrible. So I want to make that clear. But coming back to the big question is, why do people with ADHD even struggle with potentially attention and impulse control? Now, I wish I could stand here today and be like, we know exactly what's going on here. Let me tell you, I really can't. The exact mechanisms behind ADHD are still unknown, are being debated. There is a lot of conflicting research out there. So when I say etiology, that again just means the cause or set of causes of why a condition is coming about. So as far as what causes ADHD, we do not exactly know. Many researchers propose that ADHD does have a complex etiology consisting of multiple biological and environmental factors. So that's genes, environment, there's lots going on here. So essentially, I'm just going to present to you what we do know and we're going to go from there. So according to the DSM-5, very low birth weight, and we're talking less than 3.3 pounds, so very low birth weight, conveys a 2 to 3-fold risk for ADHD. Again, just because you have a low birth weight doesn't mean you're going to have ADHD, because most children with a low birth weight don't have ADHD. It's again, we're just talking about things that maybe increase the risk in combination with other stuff going on. Because again, it's complex and not straightforward. So when I say environmental toxicants, I just mean any essentially toxic substance that can be natural or human-made that we're just exposed to in the environment. Now again, we're diving into this, and I know I'm going to read it, I want to cover it up, but I want to clarify something before we talk about this. There is a big difference between correlation and causation, even though they sound similar. I don't know why they do that to us, it's so confusing. But anyways, when I'm talking about ADHD and environmental toxicants, I like to think of it as they dance in some way. And again, what that dance exactly is, we don't know, but there's a relationship there. But environmental toxicants do not necessarily cause ADHD. So none of the things that I'm about to list cause ADHD. So I know I'm anticipating parental tendency to feel overly guilty at times. And again, when we're talking about these kinds of things. So I do not want for you to think in any way, shape, or form that you have caused your child's ADHD. That's not what we're saying. So, okay. I'll come back to that. I'm gonna keep driving that one home. But the environmental toxicants correlated to ADHD include the exposure to smoke, exposure to alcohol, food or dietary reactions. This is in a minority of cases, but again, still okay to note. Maybe abuse or neglect as part of their upbringing, exposure to neurotoxins like lead, even some infections like encephalitis or even some head injuries seem to maybe be correlated, not caused. Okay, but also it has a very strong genetic factor. So heritability estimates come from studies that essentially look at twins, families, adoptive siblings to try to figure out how much of that variation of a trait can be attributed to genetic factors as opposed to environmental factors. Good old nature versus nurture. So of the psychiatric disorders, ADHD is considered to have a very high heritability estimate of about 80%. Again, in layman's terms, what does that mean? If one identical twin has ADHD, there is a 75 to 90% risk that the other twin will have ADHD as well. Now, again, that's not 100%. So that even leads us to see that, okay, genetics can't be the only thing going on here. There's something else happening at play too. But researchers have had little success, I'm gonna say, finding an individual genetic variant or genome-wide association. Not to say that they haven't found some things in that area, but nothing that would be consistent across everybody that has ADHD. So essentially with that, we can't diagnose by blood work, brain scans, genetic testing. No, that would not capture it all, because again, we don't have a one unifying theory across the board. So what do we do with that? Researchers then look to phenotypes. We're like, okay, if we can't pinpoint that, then we're just gonna look at what are some observable characteristics that people with ADHD have in common then? What is going on here? So we're gonna talk about people with ADHD seem to have these traits in common. Firstly, children and adults diagnosed with ADHD show increased reaction time variability. and when compared to, I'm going to say, non-clinical populations. So again, what does this mean? This just means when they're doing a task that requires attention, their reaction rate seems to be kind of all over the map. Sometimes they react fast, sometimes they react slow. It's just like, again, very variable. Whereas the non-clinical population is a little bit more consistent. So if someone's reacting slow, they're gonna react slow. If someone's reacting up here, they're gonna react here, but it's gonna remain more the same. So we think we know why this is, and I will get to that a little bit later on of what's happening in the brain. But secondly, individuals with ADHD tend to have troubles with time management, which includes estimating how much time is available, say for a certain task, how to track it as they're going along, and maybe how to stay within those time limits of a task. So they have difficulty even kind of potentially feeling time going by. So sometimes referred to as time blindness. It's like, oh, that much? It only felt like a few minutes to me. But time management is considered one of those executive functioning skills. And another executive functioning skill is organizational skills. So thirdly, people with ADHD tend to have subpar organizational skills. Now when I say organizational skills, this can be kind of a variety of things. Again, one of the ones that we would maybe more assume when we hear that word is creating and maintaining systems for keeping track of things and information. So just like a real world example that sometimes comes up is like the ADHD piling system, where it's like, okay, they got piles of things. It kind of makes sense to them. But like anybody on the outside would be like, yeah, that piling system does not make sense. But here's the key too. That piling system also isn't working for the person with ADHD. And we can also see that they might get very upset if someone else in the family disturbs that piling system. It's like, how dare they? But again, and if you're sitting there going, I pile, oh my. No, again, piling is a normal way to organize things. Like a pile of bills, yeah, that makes sense. A pile of receipts, yeah. Again, that's not what we're talking about here. We're talking about a system of organization that actually doesn't help the person to be organized at all. But again, that's just one example. But I feel like I saw some nods, so I feel like people are like, yeah, I've seen that, I know what you're talking about. And then as far as kind of the other maybe aspect of organizational skills, that can actually refer to a set of cognitive abilities to be able to facilitate goal-directed behavior. So essentially, again, it's gonna take some organization to even be like, hey, I wanna pass this test. In order to pass this test, I need to study. In order for me to study, I need to take this information from this, if we break it down, there is a lot of steps that can go in towards working towards a goal. And a lot of steps that require some higher order brain stuff going on here. And one of those things needed is actually working memory, which brings us to our last point here. People with ADHD tend to have difficulties with working memory. Now, again, different types of memory, but when we're talking about working memory, that is specifically the capacity to hold information and manipulate it in our head over a very short period of time. So remembering a phone number long enough to type it in your phone to dial it. Not that we do that anymore, so I'm gonna need to find a different example. I just realized we just usually click on a person's name now. But also I'm gonna say that's gonna be things like for children, the ability to follow multi-step instructions, maybe in the classroom or at home, things like that. So, and without reminders. So people with ADHD might have great memory for things like past events. Also, while you're prompting them to put away the backpack, the coat, the shoes, you're like, okay, we do this every day, but how can you recall that one thing someone said so long ago? So again, that's maybe why ADHD can look very confusing, because it's like, how can they have such strengths in some areas, but seemingly so much troubles in other areas? It's kind of confusing and maybe doesn't compute. So, but working memory, I'm gonna say, is not only gonna be important for organization, but there's actually a social aspect to that too. Even working memory is needed for things like playing a game and taking turns. If we think about it, impulse control, to wait your turn, you have to stop and pause and not take your turn. And then when it comes back to your turn, you had to have enough working memory to even remember the strategy you were gonna do or the move or the next thing. So again, I'm gonna say just some of these things that maybe we do take for granted as being easy, for kids it actually takes a lot of brain work. And a lot of these parts of their brain are very much still developing, that are the parts that do these kind of higher order executive functioning work and that prefrontal cortex. We're now figuring that, hey, that's not gonna fully cooked or developed until we're closer to 30. So again, we gotta be a little bit realistic in what we're asking of them as well. All right, I still got you. We need to move, or I know this stuff can be a little bit heavy. Okay, so we have done brain scans and neuroimaging though, and that's been very helpful because we actually found out that there are structural differences in the brain. So this includes lower than normal activity levels in the caudate nucleus, this little C structure in the middle of our brain here. Also in the globus pallidus, and if I'm saying that wrong, sorry to anybody with like a biology doctor, neuroscience degree, I tried to practice, but those words are tricky and hard. And the prefrontal cortex here. So not only do we see lower than normal activity levels, we can actually also see smaller structures of these. They can actually be a little bit tinier in the brain. So again, not to get into too much of the brain science, but what do these part of the brain even do that might be impacted? Well, the caudate nucleus functions in planning the execution of movement, but also in learning, memory, reward, motivation, emotions. So some pretty big stuff. And the globus pallidus is involved in movement, but again, its job is actually to inhibit or suppress unwanted movements. And then the prefrontal cortex, that one is just, it is there for all sorts of things. So it is active during a delay before a movement happens. It also stores that sensory information relevant to moving. On top of that, it is involved in planning, complex cognitive behavior, essentially personality expression, decision making, and moderating social behavior. So if we take a look at that list, like, that is potentially a lot of things that are going to be impacted, and like essentially, in other words, executive functioning skills are potentially impacted. So again, let's take a moment just to make sure we all understand or have an idea of what are these executive functioning skills. So again, there's going to be lots of debates of things or different things, but working memory, cognitive flexibility, and inhibitory control are going to be these three huge categories. Working memory, we've talked about. Cognitive flexibility, that's that capacity to kind of switch gears, to adjust your plan or thoughts when new information comes in, or perspectives. And inhibitory control, again, we gotta hold back before acting and thinking. So if we break it down though, this is going to be involved in planning and prioritization, that ability to see the big picture and develop those steps to accomplish the goal. The organization, the time management, the memory, the self-reflection. So even the ability to maybe reflect on successes and failures and take note of oneself in a situation. Paying attention, staying on track, self-control, getting started. So how do we actually get going on a task without a lot of procrastination happening? And that cognitive flexibility and problem solving. So again, problem solving really does involve a lot of switching, and as new information and setbacks and different obstacles come up, to persevere in order to get a goal, that is some hard work. So again, I do want to take a moment to pause because again, this is sounding a little like, whew, they're having trouble with all this. Like again, our heart goes out to them. But many people actually don't struggle with ADHD, don't struggle with a lot of these things either, and we'll talk about it. It's very confusing. But just know that, again, just because there's the potential to have these difficulties doesn't mean everyone will. Okay, so what's going on in the brain that would maybe explain what's happening here? There are two main neural circuits, DMN and CCN, that we're going to talk about. Basically, these circuits are comprised of different brain areas. I'm not going to bother telling you what they are, but just know that there's multiple systems in the brain that are coordinated by these circuits, so they do have to work together in order to make stuff happen. So the default mode network, the DMN, is active when we're not doing anything, at idle, at rest, when we're just letting our mind wander and drift. That's when that one's going to be on. The CCN then works in opposition because that is actually a task. So when we're about to do something or take action, that one is on. So essentially, while we're at rest, just letting our mind wander, that DMN should be on and the CCN should be off. If the CCN would be activated, we're going to see that switch, DMN shut off. This is not the case potentially in people with ADHD brains. We find that their systems actually coordinate. And I know when we talk about brain working together, coordination, it kind of sounds good. In this case, it's not. We actually want them to be working in opposition instead of turning on and off together. So why is this happening? We're kind of okay, if this difference is happening, what's to blame or what's the cause? That's where dopamine comes in. We're going to talk a lot about dopamine. So that is a neuromodulator, just meaning when it is present in the brain, when dopamine is there, some brain areas are more active than others. So in general, it helps modulate thinking, feeling, and acting, as well as focus and motivation. But okay, pretty important, thinking, feeling, and acting, that's life, okay, so dopamine is very much important to our day-to-day. So essentially, it's supposed to be that air traffic controller that's almost telling what to switch and what to go on. Unfortunately, we're saying, okay, if it's not doing its job properly, dopamine, telling these systems to go on and off in opposition, what's happening? Well, that's because we found people with ADHD tend to have lower dopamine levels in their brain. So, for everyone, even without ADHD, the presence of dopamine creates that heightened sense of focus and motivation. I think of it like the racehorse with blinders on, so it doesn't get distracted by the other racehorses, and it's just like eye on the target right to that finish line there. That's essentially what dopamine kind of helps us do. So the lower dopamine in a person's brain means technically those blinders are off, and the more of the world, or those senses that we talked about earlier, that they're going to be taking in. So low dopamine then might explain why we actually see them be more highly distracted. They're actually taking in more information to be distracted by. Also, low dopamine could maybe explain why children with ADHD tend to have a preference towards sugary foods. Maybe you've seen that. And that's because eating sugary foods actually releases dopamine. So again, we're like, okay, we're putting some puzzle pieces together here. And I know I talk a lot about, again, the difficulties associated with ADHD, and that can be really hard when we're thinking about that in the context of our children. So once again, that brain plasticity is possible. So when I say the brain is plastic, what do I mean by that? I mean it can mold, it can change. Essentially, experiences change the way our brain functions and different things. Right now it is happening, neuroplasticity. But it's interesting because in some studies we have found that, say, children actually reach the same cortical thickness as their peers, but we see a delay in the maturation of gray matter by a few years. So potentially 2 to 5 years behind their peers. So there is this idea too that we might see a delay in maturation, but it doesn't necessarily mean that some of these brain differences will be there through their entire life as well. Sometimes we do see some of these areas catch up. And that's why it is complex and interesting. So, I'm excited for this part. The flip side of ADHD and attention. This whole time I've been like, yeah, people with ADHD kind of struggle with attention. Yeah, that's actually kind of only like half the story. They actually have the amazing capacity to hyper-focus or laser focus, but it has to be on tasks that they find enjoyable. Yeah, so there's a key piece in there. So if you've ever noticed that pattern with children with ADHD where they're really struggling to stay on track, completing the chores, for example, but they seem to be fine doing their Legos for hours on their own. You're like, okay, why can you focus on that but not on this? It's because of dopamine. And you're not wrong, you're not crazy in witnessing those patterns either. So again, it comes back to dopamine, but it's actually its relationship with, and I know that might be cut off a little bit here, curiosity. That's what my panda bear is supposed to be representing here. So if you're seeking knowledge because of an external motivation, school, work, then it does not count as curiosity. But if you're seeking knowledge because you're internally motivated, because you just want to know, you just want to learn, that's where we see that curiosity. And when we explore our curiosity, guess what? Our brain releases dopamine. So coming back to ADHD, people can hyper-focus on enjoyable activities because it is something they are truly curious or interested in, and therefore have the increased level of dopamines in their brain needed to help them sustain that attention through that enjoyable task. And likewise, I'm going to say, kind of on the flip side, but that also means at a neurobiological level. Sorry. It's not working.
Uh-oh, now you're going to fly up to the...
I'm so sorry. No, it's okay. I'm going to take a step back in case it does that thing and I'm not going to become like a meme or something. No.
That's good, you sold it there.
Oh, thank you. That's awesome. Oh, I really appreciate that. So again though, like we need to build this understanding then for children though, that at a neurobiological level, people with ADHD cannot engage their attention for things they really don't want to do or are interested in. That is actually going to be a struggle for them. So again, this might be why we observe that attention can more easily be sustained during like novel or new experiences as well. So perhaps you've had that experience where again, a child's like begging you like, I really want to do this sport, or I really want to get into this hobby or activity. And you're like, okay, let's get the supplies, let's do it. They go to the class a couple times or they do the activity and they're having a great time. But then all of a sudden out of nowhere, they're like, yeah, no, don't want to do that anymore, I'm done. No. But I spent all this time and money and there's things piling up in the closet that are just collecting dust now. Again, that's kind of what we're talking about, but it would make sense when we come back to this dopamine hypothesis, because novel experiences, again, do give us that hit of dopamine. And then after something gets usual or boring, then we see that go away. And that's also maybe why we even see potentially increased behaviors or symptoms in really comfortable environments or regular environments for kids with ADHD as well, just because essentially it's more boring too, kind of built into it now. And if I think about this though, it's like if our brain is low in dopamine because it's not having enough, I like to say, like in an article I read, like, it comes dopamine hungry. If we can think of this like dopamine hungry brain, it's like, where's the dopamine? Give me the dopamine, I don't got enough of it. Well, that's gonna come from novel experiences. But again, like that double-edged sword, sometimes by seeking the dopamine and seeking those novel experiences, that can be distracting in itself, because then we're going from one novel experience, jumping to another novel experience, and again, we're kind of getting into this cycle of like unfinished tasks and hobbies. But at least we kind of maybe understand what is going on for them. It's not, again, not maybe just like a preference or something. It might be like a little bit out of their control, that natural reaction that they do have. Okay, so we do not have a unifying theory of ADHD. Again, we don't have like this one thing that can just explain everything that we're seeing and all this variation that we see within ADHD. So I'm just gonna tell you about the two main working theories that we do got going on right now. So the executive dysfunction theory is just explaining that, hey, ADHD symptoms, they're a product of those deficits in the executive functioning skills, especially that disinhibition or impulse control. Because of the structural differences in the brain, essentially, in the dopamine system, there's a reduction in those abilities. But again, here's where we can't just go with this theory. Some executive functions are not always greatly impaired for people in ADHD. So we go, okay, that actually doesn't explain everything we need to know. That's where state regulation theory came into play. Now, it explains that the symptoms of ADHD are associated with dysregulated states of brain arousal. So essentially, these symptoms are occurring because a person is not sufficiently aroused and therefore cannot be engaged in that task, right? It's not enjoyable enough, it's not they're not curious, essentially, there's not dopamine there. And I'm gonna say this is based on this Yerkes-Dodson law bell curve, stress curve for short, but this is actually true for everyone. So again, there's some things that are maybe a little bit more intense with ADHD, but this is somewhat true for everyone. In that when I'm saying arousal, in this case, we're talking about like kind of mental stress or mental load, how much you got going on. So when we're low, we do not perform at our best. I can imagine if I was a child and like playing volleyball in gym or something, it's like, oh, this doesn't count for really much. Like, you know, I'm not gonna give it my best effort and dive for every ball and do all that. But as I'm gonna say, maybe arousal or that stress increases, we can actually see a positive effect on performance. So, and I do think back to that volleyball example. Okay, now if I have a, during league, it counts for something. I wanna put on my best performance. Likely, I'm a little bit stressed about how I'm gonna perform, but that will probably lead me to practice, to work on my skills, to try my hardest. And again, that's where we see that peak in performance at the top of that curve. Now, it doesn't last though. When there is too much arousal, that is also a bad thing. So again, think back to that big game-winning match. It is for all the marbles, who's gonna win gold? All my friends and family there to watch me too. Okay, now anxiety and like too much stress is coming in. I might not play my best volleyball game. So again, just to let you know that this is somewhat true for everyone too. Now when it comes to these two theories, again, there is so much conflicting research, so it's very individualized, and essentially we're working with both of them, but neither one is perfect or a standalone. But I do think it's beneficial to cover this because, like I said, I'm gonna draw this in to how maybe we set up some of these strategies based on this information. Yeah, okay, some myths. So dispelling the ADHD myth. Big one. There is no such medical condition as ADHD. I kind of hope by now we're like maybe starting to move away from like ADHD doesn't exist, but I'm gonna say for a long time that was a big thing about even debating if it is a thing or not. But I am here to say that ADHD is a medical disorder. It's not a condition of a child's will. A child with ADHD does not choose to maybe misbehave or struggle with their behaviors. Now, I get it from the outside. It can sometimes look like that intentional misbehavior, or sometimes we use the word like manipulation going on. And perhaps we get into this type of thinking where we're like, they can control it. They should be able to control it. They can control it. But I'm gonna say, like, no, that's the whole point of this disorder and the brain differences, is that it's a really big struggle to actually control that. Their brain is not working the same way. So I just want to point that out because I think adopting that lens is not only like not helpful, but I actually think it does lead potentially to harm. Because in that way of thinking, we might accidentally be sending those messages through our feedback to our children that they're not trying hard enough, they're not doing good enough. And I think that's honestly maybe where some of these things with the self-esteem issues actually start to come in, about that feedback out from peers and our caregivers and things like that. And this might be an extreme example, but I just want to throw it out there. Like, could you imagine if we treated, someone or like a kid with a broken leg the same? Like, I don't know, X-ray machines are down, we can't scan to see if there's actually a broken bone, but like, oh, there's no bone popping out, so like, I think you're okay, You say it hurts, but like, could be just making an excuse. So, why don't you just go run laps in gym and just try a little harder instead of like, limping? It's like, I just want to say that just to maybe highlight some of the stigmas or biases that I think do still exist with mental health disorders, maybe in comparison to some more like physical-based disorders. So again, I think there's just room to always keep in mind that we ourselves grow up in a world that potentially has like stigmas and biases, but I would really hate for those biases to potentially, I'm going to say, become a barrier to getting good care for children and adults, essentially. So, I told you we were coming back to this one. ADHD is caused by bad parenting. All the child needs is just greater discipline. No, no, just in case, that's the myth side. That's not true. So coming back to the environmental factors, it's not caused by parenting. Here's the but, though, on something like this. Parenting techniques or approaches, I'm gonna say, can actually improve symptoms or make them worse. Just again, any way that any parent interacting with a child can like increase behaviors and sometimes make them worse. So if your parenting techniques are maybe coming from that lens of they can control it and maybe having a lack of understanding of ADHD, then I'm gonna say children with ADHD are gonna probably turn that bias inward, and it's also not gonna be helpful because at that point we're also probably missing the accommodations and supports that would actually be helpful for them to reduce the behaviors or do the work that we're wanting them to do or wanting them to be able to do. So I really like this myth and the fact that it really needs to be dispelled. Having ADHD means the person is lazy or dumb. Nope. So actually, there is no studies that like correlate like the intellectual ability and ADHD. A lot of really smart, intellectually capable people have ADHD. So that one's kind of, we can just like throw that one out the door. And then medicine for ADHD will make a person seem drugged. So again, we're gonna talk more about medication, and I know there can be some stigmas or some apprehension when we're talking about medication and things like that, but I'm gonna say properly adjusted medication for ADHD can sharpen the person's focus and increase their ability to control their behaviors. So again, there's going to be dosages, there's going to be different kinds of medication and finding the right combination, potentially. Again, that's just one option, we're going to talk about others. But if we're seeing that a person does seem drugged by their medication, that's actually a sign that we need to go check on that medication levels we're at. Maybe not that the medication itself is completely bad, but maybe we're off with our administration of them. Okay, but after all of this, what are some of the superpowers that can come from ADHD? So again, with some brain differences can, yes, come some challenges, but can also come some really cool things, or I'm gonna say some superpowers that make them, these abilities, even better than the non-clinical population. So creative problem solving. They sometimes approach things in a totally different way and see solutions that other people can't, and that's really cool. They can also have increased curiosity. I wonder why. That dopamine-hungry brain might always be searching for dopamine, and one way to do that is to be curious. But how cool is that? That they're super interested in maybe like learning a bunch of different things. Laser focus on enjoyed activities. And again, when they are enjoyable, that focus doesn't require a lot of effort for them. Like that feels easy to them to get lost in something for hours. Accepting and compassionate. Now again, maybe this is like, I maybe would or wouldn't normally put those two together because of, I'm gonna say, some of the social difficulties or peer interaction, but here's the thing. If they themselves have the experience of maybe struggling or having some difficulties, that actually might lead them to be more empathetic or understanding of other kids and people who also maybe have differences or some struggles. So that can actually be quite a beautiful thing there. Increased willingness to take risks. Like we said, maybe that does lead to some like accidental injury or like motor accident type stuff too. But hey, sometimes you gotta risk it to get the biscuit. So I'm gonna say sometimes taking the risk might pay off, and they're gonna maybe be more willing to do that than other people. And then when it comes to that large imagination, a lot of times we do see a great creativity. This is like a potential strength, enthusiasm for life. Sometimes, they're go-getters, they want those experiences. Strong intuition, so maybe listening to those gut reactions and things like that. Oh, the boundless energy. And again, I know that might be more the hyperactive impulsive than that inattention type that we talked about earlier, but there have been times where kids have left my office and I'm like, if I could only just bottle that, whatever that was, like, that's better than coffee, that's better than anything I've seen. Like, you look like you're just that Energizer bunny on the go. I would love to feel like that sometimes. And honestly, great sense of humor. And when it comes to talented multitaskers, again, you're not gonna get into it, but like no one's that great at multitasking. If we get into the neuroscience, it actually divides our attention. But if there's gonna be people that are better at it than anybody else, it might be people with ADHD. All right, so let's talk about though, this process of actually getting a diagnosis. What does that look like? Well, usually it starts by talking with your family doctor. That is a great place to start. Now this, I'm kind of going to focus in on more the children and adolescents diagnosis, but again, just know that adults, it's actually going to be very similar. They're just going to be maybe slightly different assessment tools used, or who they're interviewing about you might look a little different than when we're talking about children and teens. So again, family doctor. Doctors are great because they can diagnose and they can prescribe the medicine if you're going that route. They're essentially, and maybe coming back to it, or you've heard this before, but there's not a single test that we can do for ADHD. There's not a blood test, there's not a brain scan, and there's not even necessarily one, maybe just a good like diagnostic tool on its end. We do use the SNAP-4 here, but because it's more of a process, I'm gonna say, a process of using different variety of assessment tools and interviews to collect information. Kind of like that detective work, right? We gotta like collect the evidence on the family history. How is the child functioning in day-to-day life in different environments? What are their strengths? What are they struggling with? What are potential other health issues going on? What is their medical history? Is there something other that it could be explained? And so on and so forth. So oftentimes questionnaires like the SNAP-4 are given to both caregivers, teachers, again, the people that are gonna be spending the most time with them. And maybe for older teens, they might do like a self-assessment or bump them up to like the adult self-assessment tools if appropriate or if needed. But again, just remember to get diagnosed with ADHD, we gotta rule out those other possibilities or learning disorders. So even though, again, I'm not putting an extensive list, this might look very different from person to person too. There could be someone where it's like, yeah, I just went and got a diagnosis quite quickly, but then there could be others like, no, we did a bunch of screening to rule out all these other things because of their family history, and we needed to rule that out first before. So again, there just is a potential for variability in that process, so I kind of encourage you to maybe be patient as you go along that journey if that is something you're doing. And also, again, it's okay to advocate or again to ask for help with this too. You know, as my role as as a psychologist, I myself personally do not diagnose, but depending on the work I do, there are sometimes like letters of support that can be given that's just like saying, hey, here are some of the things that I'm seeing in this environment that would just support that I would like you to go on this assessment journey to get checked out. And things like that. So yeah, but often we do start with our doctor. Again, sometimes depending on like school systems and stuff, sometimes there's a school psychologist too. So that would maybe be the two kind of, I'd say, places to start before maybe looking into that private assessment world, because that is also a possibility too. Know that there are practitioners or doctors that can do that work in a private setting. It's just gonna cost more money at that point financially. So again, it's probably gonna maybe potentially take shorter than the systems. Again, there's gonna be pros and cons to each, but you can maybe look into that a little bit more if you get to that point. But just in general, that's kind of approximately how it's gonna look. So let's talk about these treatment options though, because like what are we gonna do about it if we get a diagnosis? Now what? So what are the treatment options available? Again, I'm going to talk about a few, but like don't treat this as like an exhaustive list of like this is everything. I'm going to highlight some big ones here, but it's not complete. Again, ADHD, complex, individualized, if you're not tired of me saying that enough. But if the presentation is varied, so do the treatment options and strategies need to be as well. So let's start with medication, since that I think is a big topic. And I'm just gonna say, I'm not here to tell you yes or no on medication. It is important to weigh the benefits and drawbacks, like as a family, before making decisions. But I also wanna point out that like medication does not cure ADHD, just as eyeglasses do not cure vision impairment. However, I'm gonna say they really help me see when I do wear them. Medication is gonna be the same. It's not going to cure ADHD, but it might help us actually, I'm going to give some support to those different brain structures and different dopamine levels to get them to a point that feels, I'm going to say, more normal or more like other people's brains that don't have this going on. So again, that's kind of the approach we're taking, but it's not considered a cure. As soon as you stop taking that medication, again, you're going to see symptoms potentially come back. Although I'm going to say, again, there's very different dosages across your life and what you need. But the big one that, again, I think people maybe are aware of or hear a lot about, because there's also like a lot of scariness with it, is this idea of stimulant medication. Now again, stimulant is going to kind of be a big category. There's different kinds of stimulants within that. I'm really not going to dive into that. Like we can spend hours on pharmacology alone kind of idea. But just in general, stimulants are the most widely used medication for managing ADHD symptoms. So to say some names that might be ringing a bell, Concerta, Ritalin, Adderall, just to name a few of the big ones. We use them because they do stimulate that dopamine system, which allows the brain parts to work more effectively with each other. In this case, in opposition, that DNM and CCN are now going to be doing what they're supposed to do in opposition. But effects are variable. For some people, these medications make a world of difference. You know, sometimes these later diagnosed adults start taking medication, they go, oh, this would have been so nice to have as a younger, things just would have been so much easier for me. That being said, sometimes these medications have no effect. So, confusing. And it might take a little bit of experimenting and playing around to see what is gonna work best for that individual person or child. So some of the common side effects may be associated with the stimulant medication are going to be that appetite loss, abdominal pain, headaches, sleep disturbances, but again, not all kids experience those things. There are also, I'm going to say, different release times of different stimulants. So there can be fast acting or longer acting and more shorter acting ones. So again, you might need to play around. What is going to work best for that child and your lifestyle kind of idea. But just so you know, like stimulants aren't the only kind of medication that are available. So there's actually non-stimulant type medication too. So we find that usually these do not work maybe as quickly as the stimulants and are not always, I'm gonna say like, again, not always work well for people. Although, again, we're finding that maybe with these, we actually need to give it more time because as these non-stimulants build up in the body and in the system, then we maybe see like more benefit from them. So it might be like kind of hanging in there. But just one of the common ones, it would be like that strategeron, if that's a name that rings a bell. So again, side effects might include nervousness, sleep problems, fatigue, upset stomach, dizziness, dry mouth, those kinds of things. They work by stimulating the norepinephrine system. Now, if you're like paying attention, you're like, wait, I haven't heard that word norepinephrine at any point during this presentation. So what is going on, and why would that medication work? Again, it's like getting into like the molecules of it, but essentially they're not the same, dopamine and norepinephrine, but they're very much related because make sure I say this right because I don't have this one memorized. Norepinephrine molecule, each norepinephrine molecule is dopa, and this tiny molecule is converted into dopamine, which then converts into norepinephrine. So again, like if we get into the chemicals, they're different, but they're very similar. So again, we're kind of interacting with this dopamine system roughly. And then there's going to be there's going to be different types of non-stimulant medication. And Intuitive, for example, is an alpha-2 agonist, we call it. And it works by just targeting a different part of that epinephrine system, essentially. But again, coming back to that dopamine hypothesis, this is why we think some of these medications do work really well for people, but then again, it's also a bit of mystery why it doesn't work across the board. But yeah, like even researching this, I went down so many rabbit holes, I'm gonna say. I'm just even trying to figure it out enough to be able to present to you guys something that's clear, concise, and not too confusing, but also highlight how different this is depending on what research articles and different things. And that's actually a good thing to know when you maybe go forth and start to do some of this research yourself. If you're like, oh, this is so confusing and things seem to be one way and then opposite and another, again, you're not crazy. That is actually what you're gonna see if you look into the research. So in general though, I like to think of medication this way. If medication is helping the brain to even momentarily, while it's present, have less trouble doing its job, then we can maybe give a kid or an adult an experience in their brain of what that is like to maybe not have as much of those struggles and troubles. And I'm gonna say, coming back to that plasticity of the brain, if we can give more experiences of that, there is potential for areas to strengthen in the brain around that, using that plasticity to our advantage. Kind of like practice makes progress. I have dropped perfect, there's no such thing. So practice makes progress. And again, I think this is helpful with medication to keep in mind when honestly talking about protecting kids' self-esteem. If they are getting experiences where they are successful, that is important. That is what's going to help protect and foster their self-esteem as we go along. If we have so much, I'm going to say struggles, without any help, any accommodation, any support, any treatment, kids are going to go, it's me. I'm bad, there's something wrong with me. They're not going to sit there and go, no, actually, you know what, my brain works in a different way and I just had struggle and I didn't have the support that I need. Like, they don't do that internal dialogue work. They go, no, I'm bad, it's me, there's a problem with me. And again, I think that's where that self-esteem gets impacted. So just moving away from medication, no, there are other things. Of course, therapy is one thing. Therapy, big umbrella term to include a lot of different types of therapy underneath there. So there can be psychoeducation for caregivers. Maybe you're doing that one right now, so good job. But also there can be, like, say, behavioral supports with parent training. Again, maybe those approaches that are gonna work best. The child themselves with ADHD can get therapy. Again, in there they can help build skills, social skills, again, maybe even work on things that would protect or build or foster self-esteem. This can look a variety of ways. Even I'm gonna say family therapy, because I think of families like solar systems. Yes, everyone is their own little planet circling around, but the gravitational push and pull of everyone's planet in the family actually changes the orbits and the patterns of other people in the family as well. So I'm gonna say family therapy might be a cool thing to explore of, like, what are the experiences of each family member, maybe with ADHD or without ADHD. We can really see some interesting things. Coming back to that genetic component, those changing reaction time variabilities. Interestingly enough, we see, again, people with ADHD have lots of variability. Non-clinical populations don't have too much. Siblings of people with ADHD fall somewhere in the middle. So again, I'm gonna say there might actually be other family members or things going on too that are impacted, or just ways to explore that. And again, I get it, I'm a psychologist, I'm gonna say I'm biased to therapy. I do think it is helpful and it works. But again, this is just one option or one thing to consider. I am almost a little apprehensive to talk about the diet stuff, but again, I don't want you to go home and go on the internet and find a whole bunch of stuff and we never even talk about it. But I really want to be clear or try not to have miscommunications around diet things as well. So if you do go online and put in diet and ADHD, you are going to get so much, and there's going to be different information from elimination diets, maybe that elimination of sugar or reduction of sugar, artificial food coloring, especially the red dye. Maybe you've heard about the red dye, fatty acid supplements, omega-3s is I saw a lot of omega-3 stuff coming up now. Okay, again, research is inconsistent. There is not the evidence to support that diet causes ADHD. So again, this can be just a direct cause thing. However, it might be reasonable to think that diet modulates or influences ADHD symptoms. But again, before we get carried away, so does parenting techniques, right? We said parenting techniques, it doesn't cause ADHD, but again, it might influence or modulate this, the symptoms. So that's why I want to just talk about this. And again, I'm not here to tell you never look into dietary stuff, no, but I would have to caution against just going into a diet-based treatment, especially I'm going to say without like doctors or professionals, as the only thing. There actually has been a lot of research on elimination diets having some big risks associated too. Sometimes we maybe found the more we eliminate, sometimes that can actually cause greater reactions or allergies later on. But again, conflicting information out there. So as we walk away today, diet is not going to fix, cure ADHD, but I'm not going to tell you that like eating maybe more healthy or in a way that again is getting the nutrients probably is just going to help in general anyway. Kind of like sleep, I think of as sleep, kind of another modulator. We're not going to say just because you had a bad, like we can imagine if a kid has ADHD, they have a bad sleep, yeah, we might see increased behaviors going on, but we're not going to sit there and go, oh, your bad sleep caused your ADHD. No, again, it can modulate it and influence it, but it's not maybe at the root of it, or we can't just attribute it all. So take into consideration diet, but do so cautiously, and please consult doctors and different things like that to make sure that we're not, potentially causing more harm than good. And then yeah, when we come to educational supports and accommodations, over the years, as we become more knowledgeable, we have seen options like wiggle seats, I'm gonna say fidgets, make their way into like classrooms and homes. Accommodation can look like things like test accommodation, so maybe giving someone more time to take an exam, having a reader for exam, things like that. But again, every individual is going to be different in what they need for accommodations as well. So even little things like allowing movement breaks during the day, that can be what we consider an accommodation. And again, maybe it's important for therapists and caregivers and educators to try to work collaboratively as a team to better support a child with ADHD and essentially reaching their full potential. So thinking back to that state regulation theory, it would make sense that by helping kids be in that optimal zone of arousal for them, we are going to see the work more easily done. And when it comes to accommodations, I'm going to say that doesn't just apply to the school environment. That can be at home as well, or daycare, or different places. So again, I know maybe when we talk about treatments, I do just want to drive home that I encourage families to experiment. And what I mean is, you know what, we're going to try things. You're going to, like, as a parent, you're going to see what's going on. You're going to maybe implement a new strategy or a new treatment option. But then I want you to collect the data. I want you to look at how that is impacting your child and what it's doing. Is it helping? Is it hurting? Is it doing nothing at this point? Once we have that little bit more data, that's when we make the adjustments based on what you're seeing. So again, I can't stand here and just be like, this is a one size fits all treatment plan. No, it's gonna be very individual. And I really do believe that as parents and caregivers, you are the expert on your child. You are the one with them the most, seeing them the most too. So I'm gonna say, like, don't consider yourself like less than a part of this process. You're a big important part of this process to see and give feedback to people like therapists like me and things to better help structure and tailor those treatment plans to individuals. Yeah, so I'm gonna say, and that can be a little, like we're just gonna trial and error it, but yeah, it is. It's gonna take some experimenting to get there. And once we get there, it might not last, which I know is not helpful. But again, as children continue to grow and change, guess what? So too are the accommodations and the supports they may need. And sometimes that actually means a lessening of supports as well, like in a fabulous way. So again, it just can look a lot different and be changing throughout their lifetime. So I'm gonna say, don't try to make it the goal to like figure it out and then just, I think of it like a video game. Oh, I got that level unlocked. I never have to go backwards now. It's just always going up from here. No, we might have to like revisit other levels and flow through them. All right, but getting to the home stuff, okay. Why did I teach you all this brain science and theories and things? Because hopefully it will benefit us when we're talking about what does that look like in your home. So if we take that executive dysfunction theory, I think it's helpful to adopt the lens of helping manage parental expectations. So there may be things that genuinely your child with ADHD struggles with. Now, again, I think in general, there is a lot of behaviors with kids that sometimes we say like, oh, I'm worried about them at this stage. And I go, no, don't worry about them. It is developmentally normal for young kids to be, I'm gonna say, energetic, to have troubles regulating their emotions. So there are gonna be certain things too that we need to be cautious of, like, are we actually expecting too much or beyond a point that person's brain can actually do those skills that we're asking them to do. So if that's happening, I'm gonna say across maybe even like non-clinical populations, then I just kind of assume that it might be even that much more easier to accidentally ask too much of a child that might be struggling with some of these things as well. And again, we want to give kids those successful experiences because otherwise they will blame themselves. Especially younger children, I'm gonna say like kind of that 12 and under. There's actually a little bit of like a brain blast that happens around that age 12 where they start to clue in that everybody has these unique cognitive experiences and a world within themselves. But up until that point, children actually don't have a very good understanding of that. They're naturally like, I'm gonna say like egotistical or driven by themselves, but again, that's just the way their brain is set up. It's not to any fault of their own. But because of that, anything that happens, they don't go, oh, I attribute that to the outside factors, or even like, I attribute it to maybe like mom and dad having an overreaction at this time. They go, oh, it's me. It's always me. It's my fault. So we really do need to be kind of careful and be aware of that. And again, one of these issues could potentially be emotional regulation. And again, that is a skill that is hard for anyone. When I say emotional regulation, that means we have to be able to, again, kind of like tune into ourselves, feel these feelings that are happening, be able to correctly label or maybe give like a feeling word or emotion to what we're experiencing, be able to tolerate that feeling, kind of sit in it for a little bit, and then be able to process it and move on from it. I'm gonna say, in my experience in the world, adults also struggle with this. Not just children. This is a really big, hard skill. To be calm, cool, collected, and connected, that is tricky. It is normal for humans, I'm gonna say, to get up, to get angry, to have emotions, these things. But in general, it's interesting that maybe why are we asking really young children to do this? But I'm going to question whether we actually have the really strong ability to do that ourselves. So, and again, I'm guilty of it too here. And so the scenario does come to mind though. We say no to a child going to the park, they throw a meltdown, like the yelling, the pounding the fist, the flailing. But then maybe as a parental response, seeing your child like that, you kind of yell back at them, like, no, we're not going, just, quiet down. And again, no shame if this is maybe an interaction, we're like, yeah, I've been there before. But it's interesting that we're like asking a child to just like maybe chill and be calm and and be regulated and nice when we're actually not even showing that own behavior ourselves. So we gotta be a little cautious on that. So in general, again, since I can't maybe give directed strategies without knowing your family history and different things like that, in general, modeling the coping strategies you want children to see, I'm gonna say with ADHD or without ADHD, is so important. You have to show them the skills that you want them to do. If you want them to learn how to breathe when they're angry, you need to breathe when you're angry. And again, this does come back to a science level. There are things that everyone has called mirror neurons. So when a child is going to witness an adult practicing that regulation, and again, I'm never saying don't get angry, but when you do get angry, practice those skills and show them those skills that you're using to calm yourself back down. Because even if they don't join you in those skills, watching you do it, it's like their brain practices it too. Kind of neat. So we really want to use these mirror neurons to our advantage. And that leads into like the idea of co-regulation too. If you're coming from this place of calm, powerful, peaceful parenting, they're gonna feel that. And they're actually gonna use that calm to help them learn that calm and take some of that on themselves. So again, without being a specific strategy though, across the board, I would see that as a huge overarching importance. And with that said, be prepared to practice, practice, practice. Repetition, repetition, repetition. Beyond the point where you feel tired of saying that thing or doing that thing. Again, and it might be for longer than we'd expect. We might be like, ooh, by this age, I would have expected you to be able to brush your teeth on your own by now. But that might not be the case. And when I think of like kind of scaffolding or providing support, I like it in this frame. Again, we're not gonna do everything for children because then they're not gonna learn themselves. Like that's not what I'm talking about here. But I'm talking about, can we provide the minimum amount of help that does make them successful though? So again, what that looks like can be variable, but we're not gonna go overboard, but we're gonna find just enough so that they get those successful experiences, so they build that confidence, so they think they're capable, so that they can move more confidently through the world. All right, and I also want to note that like, when I say practice and stuff, like when we talk about practicing executive function skills, for example, like planning, organizing, all these things, that might be like, how are we gonna practice that? That seems boring. Guess what? Playing board games and card games, oh, that hits so many executive functioning skills. It's like, it's unreal actually. So here's your full permission to go and play more games with kids because it actually is really healthy for their brain. And I'm gonna say, and social skills as well. So yeah, don't rule out Uno. Uno is powerful. Oh, and when we're talking about, you know, again, those accommodations, those things not only might look like more prompting than you even want to give and verbal reminders a lot, but also things like, can we deliver the information in maybe a different format? So can we use visual or picture charts for things like maybe hygiene routines or chores? Again, let's try to be like not just auditory, let's try to give them different ways to take in this environmental knowledge. And also, when it comes to doing things, can we break it down? Again, what might seem obvious, go clean your room. Okay, what does that look like? If I can think about a breakdown of the room, there's a floor, there's a bed, there's a closet, there might be like a desk, there's drawer, maybe there's clothes, maybe there's what does it even mean to clean up a room? So again, let's not assume that we're actually like giving like really clear, we might actually have to help break down those steps and to make tasks maybe not so overwhelming because we know maybe we're only gonna get them for a little bit of a shorter attention span on these tricky things. Can we break it down into smaller reasonable steps? So for bedroom, cleaning the room, for example, that's a great one. Can you just remove the garbage? Very specific. Can you just put the books back on the bookshelf? Can we just make the bed? Breaking it down into what those steps. I've also seen families do kind of like a quarter system. It's like you're only gonna clean this area of the room, but again, we're breaking down the room into tinier, more manageable chunks. And when I say direct communication, what I mean by this, and again, all the love in the world, but parents tend to give lectures. Yeah, like kind of. So like longer strong-line sentences, or maybe even when we're getting directions, it can kind of be confusing because we go on tangent or like just have longer. But like they're probably not listening or they're gonna miss stuff because that's the point. It's hard to listen. So again, can we give very short, clear directions that are very precise? that's just gonna make it that much easier for them. And again, and then you actually have to do less talking, which is sometimes nice too. Okay, so that's kind of how I like to see using maybe that executive dysfunction theory to guide what our at-home strategies look like. But what about that state regulation theory? So when it comes to that, I like to think about how can we create an environment at home where your child is more easily in that optimal arousal zone. So the chart here, that kind of colorful one, is sometimes called the window of tolerance. And so again, this is actually true for anyone. Diagnosed, not, just normal populations, we all have optimal zones of arousal. When too much, we call that hyper arousal. That's going to look like things like anger, you're tense, you're rigid, you're being defensive, you may be even shaking, angry, rage is coming in on this point. Then what we actually need to do is essentially too much is going on. So that's where we need the calming, the relaxing, the soothing to bring them down into that optimal zone. Opposite true in hypoarousal. When low energy, some clues that we might be there is like lack of physical movement, feeling numb, kind of that foggy mind. Have you ever done that autopilot thing where you're like, wow, I got to work and I don't even know how I got here. Like, okay, I guess I'm good at driving, or like, you know, things like that where you're just like kind of out of it but still going through your day. That might be a sign you're in hypoarousal. Now, when we're in that, we have not enough energy or maybe like dopamine stuff going on. So that's when we need those energizing, activating, and movement maybe type-based things to bring us back up into that optimal level. So again, co-regulation. Do the strategies you want your kids to do with you, and then they're co-regulating with you. And again, movement can look like all sorts of things, you know, even like spinning on a computer chair, jumping, doing animal walks, going for walks, riding bikes, doing sports, things like this. Music, I did actually have a slip earlier when I said music. So music is very important. This is one of those great ones that can only almost be used at any zone. So I say sometimes we match the music to our zone. If we're like angry and rage, we play the angry rage music. Other times we're angry and rage, I don't know, maybe we play that soothing music to come down. So again, there's some individual variability in what that works, but music and rhythm really does get at some coping or soothing type stuff. And let us not forget that power of hyper focus on enjoyable tasks. So can you sprinkle in things that they're interested in or enjoy in any ways? I think of it like, can we put a Spider-Man sticker on the toothpaste? You know, can we get these things? Can we adapt the ways of doing things to actually make it appealing to their enjoyable tasks? A lot of times, again, they have great creativity and imagination. Can we say, oh, let's pretend to be this character as, you know, as we clean up the house or things like that? So again, I'm gonna say coping strategies and accommodations can actually have a lot of, I'm gonna say like fun and playfulness in them too. It's not just like, yeah, sit down and work on a skill now. In fact, that's probably not gonna be a great approach for your children with ADHD. All right, last but not least, I promised you one technique though to maybe try at home, the sandwich technique. So can we basically, again, the idea of working on this dopamine hypothesis, can we allow them to do 15 minutes of enjoyable activity? I get that switching tasks might be a little tricky, so this part of it might take practice, so that's where we're bringing this strategy in. But can we set a timer, let them actually do an enjoyable task, and then only ask 5 minutes of work from them after this enjoyable time. Followed up, sandwiched it by the enjoyable activity again. Again, the idea behind this is, can we give their brains enough dopamine during the enjoyable activity to kind of sustain them during that hard work, as it's probably going to go down, and then we build it back up again. So also I find maybe even like for adults or people too, sometimes we get on a roll. And that 5 minutes of work is like just the getting started was actually the hardest part. Another minute is not so bad, and you can roll. So again, like if you're on a roll, leave it. If the child's on a roll, leave it. Come back to the enjoyable activity when they're finally ready to take a break. Also, I'm gonna say this 15, 5, 15 is not like an exact science of those numbers. So again, play around with them and see what maybe works best, or don't, because that's the point. You're allowed to take with you what you will and leave the rest here today. But I know I've talked for a long time and I'm getting tired of my own voice, so does anybody else want to do some talking or ask some questions?
I have a couple of questions.
Absolutely.
So when we were talking about the causation, or I guess where it comes from, but can ADHD be developed in adulthood? Like, can you be asymptomatic until a certain age?
that is a highly debatable topic right now. That's a great one to bring up. So because it's under the neurodevelopmental category, I'm gonna say technically right now, no.
Right.
But as we're seeing, I'm seeing a lot of advocacy for adults who go, okay, if I needed to have these symptoms present before the age of 12, maybe they were there, but like, I have maybe ADHD and I have a hard time remembering. My parents might have, so like there is some debate right now whether that is the best approach to go, because I think there is the potential for adults to have ADHD, but maybe are missing that diagnosis just because we can't attribute back to that younger than 12 criteria. So, and that's why I even say like everything is kind of constantly evolving and changing as these things come up, because we're like, ooh, maybe we do need to actually adjust our diagnostic criteria to make room for some of these things that we are talking about. So that's why every, again, so many years that DSM actually does get revised based on things like that. Yeah. So again, I wish I could give a clearer answer, but I'm gonna say I think there's also the idea that potentially, I'm gonna say, again, at certain levels, we might see, guess what, they didn't struggle a lot when they were younger. But as they got older and the work got harder and things started to pile up, again, we might now be like kind of crossing that threshold line where we do really start to see those deficits or struggle. So again, debatable, it's like, was it always there and just like at a like undiagnosable level, or but I think when it comes to diagnosing, I should even say like sometimes labels are helpful and sometimes they're not too. There's definitely people who are like, because of this, I maybe even start being mean to myself, because it's like, okay, I can understand why I'm the way I am and I'm not just doing that self-blame thing. For other people, they're like, you know what, just even having understanding that this might be going on for me is good enough, but like I don't feel the need to get an official diagnosis too. So so maybe kind of answer.
Yeah, no, for sure.
Yeah.
And then my other question,
Yeah.
you touched on a little bit, I was wondering whether symptoms can come and go.
Mm.
Can you see different symptoms at one point and say you're getting treatment for it, and then other things can develop, at other times?
Yeah, and I would say like again, intensity is gonna maybe like look a little different or coming up. Even like at that point too, we could even be like kind of curious whether it's like, again, is that just a different ADHD symptom, or did maybe we miss they have anxiety and ADHD, and now that's like the overlap that we're seeing, or different things. But I'm gonna say, again, it's so variable in its own presentation that I would say that we do see changes. And that's why even some adults and kind of like meet that criteria for partial remission, because it's like there's some still stuff going on, but again, not as many symptoms as there to even get that initial diagnosis. Yeah.
I have a question from online.
I forgot you were there. Hi, everyone.
No.
Online baby.
So one of our online watchers is wondering, what does the research say about ADHD in males versus females? She's hearing a lot about adult women finding ADHD diagnosis, but it looks different from the traditional symptoms.
Yes, so that kind of goes back to that inattentive predominantly type versus the hyperactive impulsive type. And actually, just because I feel like I'm doing the hand movements anyway, I'm just gonna throw it back up, because I'm a visual person, that helps me. So the idea is that we see females more with that inattentive type and males more with the hyperactive impulsivity. But because the inattention type alone, again, doesn't necessarily look that outward, a lot of the symptoms are kind of like inward, a little spaciness, a little anxious, a little things going in this direction. I'm gonna say we can kind of miss them earlier on. So I think that's why we're seeing, again, like older, like women or adult women being like, oh, this is what's going on. Maybe because they did, I'm gonna say, kind of fell through the cracks of this criteria when we were, I'm gonna say, maybe at one time, as I said, more focused on the kid running around because of the disruption factor. So I'm gonna say, people that present with the inattention type, again, they're spacing out in the back of the classroom maybe. Again, that's gonna be bad for them not taking in the information, but is it disrupting the whole classroom? No. So I think that's where it kind of gets sneaky and goes a little bit hidden because it's not causing the disturbances. But yeah, even in the DSM, they will say there's a difference between primarily what like the female and males get as that diagnosis. Yeah, so yeah, that's right in line with what we're seeing online in that regard. Yeah.
Quick question I had was, could somebody start out as a child in one of these groups and end up as an adult in the other? Like, does it change?
No, that's interesting. Think about that for a moment.
curious question, so I answer.
Yeah. Oh, just basically, can someone start off as a child maybe like being like predominantly one type, but then as they go along, could it change the subtype or things like that? I'm gonna say I actually honestly don't know. Maybe if I'm gonna be like honest, I could see the potential. Again, I'm trying to think back to the diagnostic criteria, because in order to even get one type, we have to actually rule out that we're not seeing enough of the other type. And I think at that point it might be like a little unlike, like maybe it would be just under threshold, but I think if it's close, we just go with combined type anyway. I'm gonna say I'm not gonna like. Again, I think anything's possible. A lot of times I'm not gonna rule it out completely, but I haven't come across that in my experience, or don't know off the top of my head. Yeah, good question. Yeah.
I just feel that maybe that happened to me.
Yeah, absolutely. And again, that's the thing. And I want to say, like, sometimes when we do like research or journals, again, even I take everything with a grain of salt, because like what you kind of described, what we call like quantitative evidence, right? Like someone's own lived experience and what they can tell is actually also a form of scientific evidence in one way. It's just sometimes that hasn't got like the credit in the literature as some of these other like more number-based or qualitative or quantitative approaches kind of idea. Yeah, yeah.
Do you have a suggestion on how to like align parents' mentality with what you were saying, like the child's ability to perform certain tasks being due to ADHD, where that parent sees that their child is actually quite capable in many ways? Do you have any suggestions on how to like shift that mindset from they may be able to do these many things because you think they're capable of doing foreign tasks as well, to they're able to do these things but not able to do these things? And also, if you've made mistakes along the way over the years, do you have any suggestions on how to repair that so that the child doesn't have those self-esteem?
Yeah, absolutely. And I'm gonna say with anything, so I'm saying everything is plastic. I'm gonna say there's no point where it's like we've gone too far or like we can't come back for it. Something. So I just will like lay that out there for the hopefulness. Yeah, in general, I'm gonna say sometimes again, tracking I find is just a little helpful. So an example is like, let's even just make a column of like, what do they struggle with? What are they good at? And again, it's like even sometimes just like, again, I'm visual. So if I put that out on paper, it also becomes, I'm gonna say, a cheat sheet to maybe remind ourselves if we're feeling like, oh, I'm really frustrated, they're not doing this. We can always be like, wait, can I go back to the sheet and just see like, was this something that actually fell into the category that they struggle with, or was this a strength? So I'm gonna say there can kind of be like self-cheat sheets that we can do to maybe help with that. But again, I think maybe like the more learning we do about it too, again, it eventually like kind of sinks in, or the more we work with this, and like really, yeah, like going off the kid's reaction. And then as far as self-esteem, I'm gonna say a lot of positive praise when they're doing something right, but a lot of connection. So I'm gonna say again, like parent-caregiver connection is really gonna foster that self-esteem for a youth. So can there be times where you do like, I'm gonna say like date nights, and especially if you have like multiple siblings or like children, I say like, can you give one-on-one attention and certain times to the one child to just have that really quality connection time? Because yeah, when we talk about repair work, that's what it is. And I'm gonna say, it's okay to actually even apologize to your kids. So be like, you know what? I didn't know very much about this. Guess what? I've learned more, so I'm gonna make adjustments. That comes back to the modeling we were actually talking about earlier. How do we say like, hey, you know what? I maybe made a mistake, but here I am owning up to it, and here's my promise or like thing that I'm gonna do to be better in the future. To me, that's fabulous, because then essentially you're showing the kid, again, what you would want them to do if they have repairs and relationships at any point in their life. Yeah, no problem, yeah. Oh, wait. Hello.
I was wondering if you have any strategies you can give for time management. So I have a 13-year-old daughter, so getting ready in the morning to go catch the bus is a struggle. I use text cards. I have a written checklist. I do a 5-minute check-in. The 5-minute check-in just pisses her off. And so when I don't do 5-minute check-in,
Again, we're going off the evidence, right? Was that working? Is it not? No.
so I'm lost. I don't know what to do to make sure that she gets her needs done so that she can get on the bus.
And my first, like, and again, this is gonna be very like solution focused, but throwing it out there, is there any of that work that can be done the night before? So I kind of think about like that sometimes preparatory, like can we lay the clothes out the night before? Can we know like how we're gonna do, how like, I don't know, heatless curls or a thing, or like, you know, whatever the case is, but like, are there some things that we can actually do the night before so it doesn't all land on this morning when it is like go, 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 or high pressure stress time?
Yeah, we do that. Clothes are laid
Yeah.
out, her hairbrush is laid out, everything's laid
Yeah.
out. And the EA sounds very good at organizing.
Yes.
Bitch doesn't want to wear those clothes.
That was last night's me. I'm totally different now. Yeah. I'm gonna throw it out there, and again, like this is not to be insulting or anything, but like, have you asked them?
Yeah, she's like,
Yeah.
I don't know.
Yeah, she- Yeah. I know. Sometimes I can give great ideas. Other times, yeah, that is the reaction I get. Oh, like focus plan, visual reminders. And like there is a certain amount, and I'm gonna say I'm wondering if this like might be part of it too, or going on, is that, you know, I was just saying like curiosity increases dopamine and things like that, but like so does kind of like a certain level of like I don't say like stress or pressure. So like that's something I did in it, but sometimes we can see actually them perform when there is that. I'm kind of even curious or just wondering if kind of the countdown to getting ready or that panic in some ways is helping or hurting. Like I'd have to be very curious about that. I know, and like again, this is where it's gonna be like, oh, it's very hard. Even like I'm like, oh, I want to be able to give you an answer, but again, even the psychology is like, okay, but I need to know family hit, or like there's like other things too that I would like. But I would say, can you sit down with them and be like, okay, whatever's working is not working right now, okay? So I'm gonna like have some idea. We're gonna do some idea. We're gonna like come this together. Let's try something. Now, when we're doing the experimenting too, this is maybe important for everyone. Try not to experiment too much all at once. If we're like changing all these factors, then we're actually not gonna like be able to like pinpoint like what was the thing that was maybe helping or hurting. So maybe with that morning routine, you can be like, okay, what things do we keep and what things do we just try a different way of doing it? Again, give it enough time, maybe a week or two to track it and get them to like rate it. Was that help? Was that not? But I'm gonna say maybe even gaining them into more of that process of what to do might get their buy-in a little bit more too. Yeah, I know that's general, I guess. I have a bad thing when we go to drama triangle. I want to be a rescuer, so I'm like, I just want to help. But also I recognize that, yeah, that's gonna look really individual. Yeah. Yeah.
I'm just wondering, like, when I was growing up, for example, I don't think I knew about ADHD, so it seems more commonplace now. I'm wondering if that's true or if there's just a greater understanding of it now and it was just going like more undiagnosed in the past or like in prior generations.
I definitely looked this up because I anticipated this question. So yeah, it's actually interesting, even though I'm gonna say it like feels or it seems because of like this information out there that like we maybe seen like this big increase. But again, there's not actually a lot of evidence to support that is happening, like overdiagnosis or under that, like, so it's kind of interesting. I'm gonna say, I think society as a culture, I'm hearing about it a lot, but when it actually comes to the research, there isn't a lot to support that the numbers are changing that drastically, which is kind of interesting and again, kind of perplexing. So I don't exactly know why, but again, from the information that it's almost always been included actually as like in a myth in the category of the things that I've seen. Yeah, which is kind of interesting. So take it with a grain of salt, but yeah.
We have another question from online. So this one says, I'm seeing the term ADHD
Yeah. Yeah.
online quite a bit. Is there any comorbidity or correlation between ADHD and autism? And do you feel that there are misdiagnoses because they have many of the same symptoms?
Yeah, so I think, yeah, like ADHD just has like, encourages to have like different comorbidities. I would say like autism is going to be one of them. Sorry, there was a second part to that though, and even my brain just didn't catch it. About better.
I'm seeing the term. Is there any correlation? Do you feel that there are misdiagnoses because of that?
I'm gonna say that's even hard for me. Like I really am not kind of in the diagnosis world necessarily myself. Yeah, I just feel like, I don't really have an opinion. I don't have an informed opinion on that. And when I don't have an informed opinion, then I don't give one. I'm gonna say in that case. But yes, if for people that are seeing, you might see this AU kind of ADHD type thing, and that's why we're saying we're seeing a combined presentation of like, yes, they have autism and ADHD as well. And again, that is a potential possibility. So I wouldn't rule it out, or like, again, to get that diagnosis, we're gonna have to like decide if they're meeting enough criteria, both of those categories, to have that going on together. But it's definitely possible. Yeah. Yeah. Yeah.
Do you have like a quick list of community resources for kids with ADHD? Like I work in mental health and addictions, but with adults, so we would have like a community links book that has all these different resources for the supports within the community. Do you guys have that outside of the realm of counseling, medication, FSCD, like those sorts of things? Is there suggestions for that?
You know what? Not that I know specific, because I'm gonna say I use the community links book too. Yeah. So when you said that,
I can offer some.
yeah.
In children's mental health, in the children's area, there's Connie Manager and Kodak. We've had them at the school, they come and do teachings around ADHD. They also do in-home support for families that are really struggling.
Is that through FSCD or is that through the provincial?
It's through the provincial. Yeah. You have to call access.
Okay.
Yeah.
Yeah, I'm gonna say, yeah, there's not like, you know, sitting here, I can't be like, there's a place for like ADHD work specifically going on in Lethbridge, but I'm gonna say, yeah, like mental health centers in general. And then, yeah, I feel like therapists and stuff can at least, when you start to maybe work with them or stuff, point you to, I'm gonna say, reputable websites or information that does have, yeah, some reputable criteria behind it. But yeah, I'm gonna say that maybe also highlights a need for these things or resource building as well. Because again, in my experience, building this slideshow was not easy by any means, going through these rabbit holes of research, and like I've done a thesis, like in fact I'm quite practiced at this, so it does make me maybe concerned for people that are just, you know, going out and trying to, you know, look into Google and see what they're coming up with. There's so much different things they're going to see, so I always, yeah, look for, and again, reputable source is going to be, again, maybe hard to pinpoint on our own, but really getting that guidance, I'm going to say maybe like, yeah, from some mental health professionals or from areas or buildings and I'm going to say workplaces that specialize in that. But yeah, as far as maybe like a general, I don't know if there's just like a nice summary sheet out there of all these kinds of things. I do know, like I think it's CHADD, Chad has some really good like informational handouts as a website, and there is one that gets very detailed into medication. So that was, and essentially you guys have the handouts here. There's going to be some like links on resources and references and different things like that to maybe, you know, maybe even have a little bit of a start there too. Yeah.
I don't want to call like a huge amount of attention
Yeah.
to pharmacology,
Yeah.
because that is a rabbit hole in and of itself.
Yeah.
But when you look at the different types between antibiotic action, is there any correlation between whether you use a stimulant or non-stimulant?
You know what? Again, I'm gonna be honest. I don't know. Yeah, I didn't come across that when I was getting into it, but that would be interesting to see. I know sometimes, for example, those non-stimulants are prescribed when someone's even potentially like has a bad reaction to a stimulant or can't take a stimulant, then that at least is like providing that secondary option. But yeah, I don't know if there's any like specific, and again, not to say it doesn't exist, but I just, on the top of my head, I don't know. Yeah, but great question of like, maybe these different, again, these different presentations can look really different, so perhaps some medication is better geared towards one or the other. Yeah.
Do you find when children go on medication that their like superpowers, they go away? Like, are they less creative, less risk takers?
You know what? I haven't come across that being specifically, yeah, like brought to my attention. I would say very much, I have worked with children who, I'm gonna say when I saw them, they weren't on medication, and then we continued our work. But as far as like even doing like very like play-based creative interventions, I haven't personally like witnessed an observable enough difference to be able to say that. But it would be interesting to be curious about, I would say. That being said, I'm gonna say maybe some of those things are there, and we are just like helping with the attention and impulse piece of the medication, but there is potential that medication isn't necessarily impacting those other strengths and abilities that are already there. Yeah, but yeah, that was an interesting thought for sure. Alright. Cool, I think so. And I want to thank everyone for being here and sticking with me on these ups and downs of ADHD. If you can walk away with anything today, it's complicated and we got to individualize support that treatment. I would say that was like the big overarching message. But again, also, I'm going to say, give yourself a pat on the back for taking the time to come out to something